Very good afternoon, everyone. Welcome on behalf of Department of Gastroenterology and GI Surgery, and also on behalf of Department of Radiology and Pathology. In collaboration with the Department of Pathology and Radiology, we'll make a case presentation with a very interesting patient, and I think we will leave some learning notes for all of us. For that, this case will be controlled by Dr. Soumya Jagannath, who is our assistant professor, and the case will be discussed by Dr. AIIMS, who is a senior resident in our department, and also by Dr. Manas Vaishnav. He's a fellow in hepatology. So over to AIIMS, Vaishnav, and also we have colleagues from pathology and radiology.
Thank you so much, sir, for the kind introduction. Good afternoon and welcome to everybody. On behalf of the Department of Gastroenterology, we'd like to walk you around this case, an interesting case of a 56-year-old gentleman who presented to us in the second wave of COVID-19 pandemic. He presented to us in March 2021 with chief complaints of intermittent abdominal discomfort for the past 3 months. His history traces back to 1991, when he underwent splenectomy after a road traffic accident. Then, in 2006, he was diagnosed with type 2 diabetes mellitus and was started on oral anti-hyperglycemic agents. And he was asymptomatic till Jan 2021, when he had jaundice for 10 days and was detected outside to have HCV infection. Then he presented to us in March 2021 with complaints of intermittent abdominal discomfort for the past 3 months. On further history, we found a history of significant alcohol consumption in serogenic doses, while there were no other features of decompensation. On examination, he was vitally stable and there were no peripheral stigmata of chronic liver disease. And on systemic examination, he had palpable liver 2 cm below the costal margin, while the spleen was not palpable, and other respiratory, cardiovascular and neurological examination were non-contributory. Coming to baseline investigations, he had mild leukocytosis with lymphocytosis. In terms of liver parameters, he had preserved liver function with normal bilirubin with slightly raised transaminases, and preserved albumin and INR suggestive of preserved synthetic function, while renal parameters were normal. His anti-HCV was positive and HCV RNA levels were detected. His viral parameters for hepatitis B were negative and his HbA1c was 7.7%. For further evaluation of chronic liver disease, FibroScan revealed a high LSM suggestive of compensated advanced chronic liver disease, which is a non-invasive marker for fibrosis, and upper GI endoscopy didn't reveal any varices. In view of his underlying HCV status and compensated advanced chronic liver disease, we did a screening for hepatocellular carcinoma, which revealed high AFP levels of 6,136 nanogram per ml, with the reference range being less than 7. Also, an ultrasound abdomen, which was done outside, revealed hepatomegaly with periportal and peripancreatic lymph nodes. So we went ahead with advanced imaging to further evaluate for hepatocellular carcinoma, and I'd like to invite Dr. Anjali from the Department of Radiodiagnosis to tell us the interpretation of the scene.
Good afternoon, everyone. I'm Dr. Anjali, Senior Resident from the Department of Radiodiagnosis, and I'll be presenting the imaging findings for this case. So we have the triple phase contrast enhanced MRI of upper abdomen dated 2nd of April 2021. There is a large T2 hyperintense lesion involving segment 8 of right lobe, which shows non-rim type of enhancement on arterial phase images and areas of washout on venous and delayed phase images. An enlarged periportal node of approximately 2.5 cm SAD is also seen. So in a background of chronic liver disease, findings are consistent with a LIRETS 5 lesion, that is hepatocellular carcinoma with extrahepatic spread in the form of abdominal lymphadenopathy. This is one of the tumor where radiological imaging is diagnostic and biopsy is not needed in any LIRETS 5 lesion. Subsequently performed PET-CT showed significant uptake in the primary lesion in segment 8 as well as in the periportal node.
So thank you, ma'am. After this history, examination and investigative workup, our final diagnosis was hepatocellular carcinoma with BCLC stage being C PCLC is a system that is used to risk stratify and further treat the patients of hepatocellular carcinoma that we'll see later. He had preserved performance status 1 and an AFP producing tumor. He also had underlying compensated advanced chronic liver disease. The etiology being dual, he had underlying HCV and also significant alcohol consumption, with preserved liver functions in the form of child A status, mild sodium being 12, and no varices on upper GI endoscopy, and also an underlying type 2 diabetes mellitus, which was being managed on oral anti-hyperglycemic agents. So now let's see how do we manage such patients and what are the treatment options for hepatocellular carcinoma. Treatment options for hepatocellular carcinoma depend on three things. First is the tumor burden, second is the status of the liver, and third is the status of the patient. So in this case, we know that the hepatocellular carcinoma had extrahepatic spread. So this was coming in advanced stage with extrahepatic spread, with a preserved liver status in form of child A status and preserved performance status of the patient, as the patient was just symptomatic with he was able to perform all his activities of daily living well. 10 years back, the main therapy for hepatocellular carcinoma was sorafenib, with the expected median overall survival rate of 6.4 to 10.7 months in Eastern and Western data respectively. But over the recent 6-7 years, several new pharmacological developments have taken place in this area of advanced stage hepatocellular carcinoma, with expected survival rate now improving to more than 2 years. So these systemic therapy include mainly immunotherapy, which we'll discuss later, as well as tyrosine kinase inhibitors. So for treatment of this patient for hepatocellular carcinoma, he presented to us during the peak of COVID-19 pandemic when there was lockdown and he was not able to physically visit the AIIMS OPD. So on teleconsultation basis, he was started on lenvatinib, which is a tyrosine kinase inhibitor, for 3 months from May 2021 till July 2021. And when he was able to visit us physically and follow up, we started him on immunotherapy, which was atezolizumab and bevacizumab once every 3 weekly. So he received total 11 sessions of immunotherapy from July 21 till March 2022. Now I'd like to invite Dr. Anjali again to tell us how we monitor response of therapy and what was the response seen in this case.
According to the modified RECIST criteria, we measured the largest dimension of the enhancing portion of the tumor, and complete response is said when there is disappearance of all intratumoral arterial enhancement in all the target lesions. In this post-treatment follow-up PET-CT dated October 2021, there is marked reduction in size of the segment 8 lesion, which shows no significant uptake on the PET images. Similarly, there is no uptake in the periportal node as well. On follow-up MR dated January 2022, we see a wedge-shaped T2 hyperintense area in segment 8, which shows no arterial or venous phase enhancement, suggestive of complete response. The periportal node has also significantly reduced in size with an SAD of less than 1 centimeter. Subsequent follow-up MR done in November 2022 and Feb 2023 also showed complete response.
So summarizing this case, we had made the diagnosis of hepatocellular carcinoma in April 2021, after which for 3 months our patient received a tyrosine kinase inhibitor lenvatinib, after which he received 11 sessions of immunotherapy, atezolizumab and bevacizumab, after which he was maintained off treatment. He attained complete response in October 2021 and has been on complete response since then. In terms of imaging response and biochemical response, we see that compared to the baseline AFP levels of 6,136, he had a drastic reduction in AFP, and which remained less than 7 on treatment and then again off treatment, and the imaging response showed complete response, which was maintained until the last follow-up of March 2023. At this point of time, I'd like to invite Dr. Manas to further discuss the review of literature in this regard.
Thank you, Dr. Ayush. Now we'll see the review of literature regarding the treatment of advanced hepatocellular carcinoma. HCC has a complex tumor microenvironment which has cell produces the immune evasion and carcinogenesis via secretion of IL-10, immunosuppressive cytokines in response to antigens, expression of inhibitory immune checkpoint ligands like PD-L1, promotion of angiogenesis via VEGF pathway, and recruitment of T regulatory cells and IL-17 expressing CD4 T helper cells. So the treatment options for the advanced HCC are limited. This was the first drug sorafenib introduced in 2008, which has improved the survival of median of around 2.1 months as compared to the placebo. And the sorafenib remained the main line of drug till the next 10 years, when another drug, tyrosine kinase inhibitor, lenvatinib, was introduced. Lenvatinib had similar survival as compared to the sorafenib, but significantly higher progression-free survival as compared to the sorafenib. However, when both these drugs are given in a therapeutic dose, they are associated with significant side effects like hypertension, diarrhea, and hand-foot-mouth syndrome. It requires discontinuation in up to 30% of patients. So there was an unmet need for the treatment of advanced HCC, and there comes a new kid in a block in the form of immunotherapy. So while we are discussing immunotherapy, we are mainly focused on the immune checkpoint inhibitors. Our body has mechanisms of immune protection in the form of immune checkpoints. So immune checkpoints are present on the T cells, which keeps the T cells in the off mode. So they protect the normal body cells by the attack of T cells. This tumor takes the advantage of this off mode and escapes from the T cells pathway and protects themselves. So what are these immune checkpoints? These immune checkpoints are CTLA4 and PD1 present on the T cells, as well as the ligand PDL1 present on the tumor cells. So how does this immunotherapy works? Immunotherapy are antibodies either against CTLA4 or either against PD1 or a PDL1, which binds with these immune checkpoints and releases the brake. This results in activation of the T cells, and thereby now these activated T cells can eliminate the tumor cells. So immunotherapy in HCC was introduced in the form of nivolumab in 2017 based on this checkmate study, but this study had demerit of lack of randomized control arm. So the nivolumab, when was compared with the sorafenib in the subsequent trial, it had almost similar survival as compared to the sorafenib, and the nivolumab was discontinued for the second line treatment in the HCC. Then comes the combination of immunotherapy with a VEGF inhibitor, that is atezolizumab plus bevacizumab. So atezolizumab is a PDL1 inhibitor. When given in combination with the bevacizumab with the VEGF inhibitors, this improves the survival significantly when compared with the standard of care, that is sorafenib. So it has a significantly higher overall survival as well as significantly higher progression-free survival. Based on data of this trial, FDA approved atezolizumab plus bevacizumab for unresectable hepatocellular carcinoma as a first-line treatment. Subsequently, when these patients were followed up for up to 2 years, they had a median survival of 19.2 months as compared to the 13.4 months in the sorafenib. And this is one of the highest achievable survival for the advanced HCC treatment currently available. Now we see the real world experience of the response to immunotherapy. So complete response rate is seen in up to 5.5% patient, and partial response rate are seen into up to 30% of patients when they receive this atezolizumab bevacizumab. In our own experience, we had a complete response rate in 15.8% and partial response rate in 21.1%. Another combination of immunotherapy, tremelimumab plus durvalumab, was approved as a first-line treatment for advanced unresectable HCC based on this Himalayan trial published in 2022. So once we know that immunotherapy are the first-line treatment, we need to manage the portal hypertension in patient with cirrhosis. So the screening upper GI endoscopy should be performed, and if the varices are present, patient should be started on non-selective beta blockers, and if intolerant, patient should undergo endoscopic variceal band ligation. Once we decided to give the immunotherapy, can we predict the response to immunotherapy? So the data is are scant, since these are the new molecules and these markers are evolving. So currently available data suggests that etiology of chronic liver disease, that is a non-viral as compared to the viral, pre-treatment low neutrophil to lymphocyte ratio, baseline alpha fetoprotein and CRP levels, and change in alpha fetoprotein at 6 weeks can predict the response to immunotherapy. These immunotherapy are checkpoint inhibitors, so they are associated with side effects which can involve almost all the organ system. However, these side effects are very mild and as compared to the previously approved TKIs, and most common involvement are dermatological, GI, endocrine and pulmonary. So this immunotherapy comes with a cost. So major limitation in giving this immunotherapy is the cost, as previously available treatment was significantly cheaper as compared to the Ates-Bevacizumab, which cost 1,40,000 for a one cycle. So what are the way forward? Now we have seen the atezolizumab. Yes. Sir, basically the immunotherapy, the endpoint defined for the stopping of immunotherapy is development of significant side effects, or there are non-response to the immunotherapy. V6, no definite endpoint. So what are the way forward? So as we have seen, many combinations are in the pipeline for the approval as a first and second line therapy, along with the previously mentioned drug, that is TKIs. And these immunotherapies are also combined with the locoregional therapy in the form of transarterial chemoembolization and as well as selective internal radiation therapy. So these trials are in recruitment phase and we are eagerly waiting for the data of these trials. So in nutshell, current role of immunotherapy are proven in advanced stage of disease, and they are currently exploring the role of immunotherapy in intermediate, early as well as very early stage of the HCC. Now I would like to invite Dr. Soumya for the concluding remarks.
So to summarize, we have seen a case which is locally advanced hepatocellular carcinoma, which is not amenable for surgical resection or locoregional therapy such as transarterial chemoembolization, and the expected median survival with standard of care therapy, which is sorafenib, was 7 to 9 months only. And in this case, after giving biologic therapy, so approximately 10% of patients respond to immunotherapy. The patient has complete remission, and even after stopping the drug also after 6 cycles for last 1 year, there is no progression of the disease, and we are planning for a liver transplantation for this patient. So to summarize, most of the patients with hepatocellular carcinoma present in advanced stage, and up to 10% of patient response to immunotherapy, and these drugs are relatively safe with minimal adverse events, while the major limitation is cost. We are since these drugs are new to the field of oncology, the predictor of response are few and it is evolving, and further research is warranted to combine these drugs with other form of therapy and use in earlier phase of hepatocellular carcinoma. Now the house is open for questions.
Congratulations on that. A couple of things that behavior. I see a no tissue. This patient got no tissue at all. So is there any role of PD-1 markers, IHC of PD-1 levels as well as MSI prior to starting on therapy response?
Sir, in this patient we could not obtain the tissue because of the COVID issues at that time, but subsequently prior to starting immunotherapy we take a biopsy and stain for PD and PD-L1. However, the data shows that the response rate is not dependent upon the staining, so the data are mixed and still more data is needed to demonstrate the efficacy if the patient has a positive PD-1 staining and the response rate.
Right. And the second thing was about the side effects. I mean, it's good you haven't got them, but we have a recent amount of experience both with TKIs and the checkpoint inhibitors in urology, which are quite regularly actually. And although we don't use bevacizumab as much, or we won't use Eliso as much, we use Pembrolizumab. And the side effects are significant. So, although it does seem to be all nice that you can now just see them on some drugs and not well, the fact that the number of patients who can actually handle checkpoint inhibitors, Pembrolizumab for long is not all that easy. It's not nice, but there are patients who really have significant adverse effects, particularly.
As about with hepatocellular cancer is if you get a complete response, we can subject it to liver transplantation and subsequently we can.
There's nothing like you have to take all the adverse effects. Just like to be aware that the side effects are not really minimal. There are a number of patients who really do have significant adverse effects. That's one of the commonest reasons for discontinuing the checkpoint inhibitor. I agree with what you said that there is no endpoint. You actually don't know how to stop. Should you stop at 6 months? Should you stop at 20 to get CR? How long should CR be sustained before the stop? There are no endpoints. But one of the commonest reasons is actually adverse effects, which is why you can stop. Otherwise, excellent achievement, about 15% complete response is remarkable.
If there are no more questions, we'd like to thank everyone. And now I will hand over the questions to Department of Cases.
Good afternoon, all of you. I joined in late, but I know about this topic, gastromedicine. It's a good work done by them. The case which we are going to present is a patient who had ingested acid. Accident or suicidal, we are not very sure. There are conflict of report on this. About 1 in 5% in Indian population documented to have taken acid, small or bigger amount, and this guy took acid and with most probably suicidal intent, and it is studied that most of these acid intake are done for a suicidal intent. They want to die, but actually they do not die. Actually, acid doesn't kill, acid tortures. And this is the greatest proof of this statement. This patient over a period of 2 years suffered from everything that is explained as a complication or sequelae of acid ingestion in a person, say in the book, rather a step ahead of that. He underwent 3 surgeries. 2 of them were very complicated to understand. We were trying to make it as simple as possible. So if there is any problem in understanding the surgery, then I will clarify later on. We have 2 senior residents to present. First, Dr. Mithun will present the case, and then Dr. Aman will tell about the review of the literature, which is very sparse in this aspect, and then we'll discuss. And
thank you for the kind introduction, sir. On behalf of gastrosurgery team, I extend a warm welcome to the faculties and the colleagues present here. So here I'll be talking about a case of a complicated acid injury of esophagus. So he's a 24-year-old male student from Delhi who presented to us in 2020 with alleged history of accidental query suicidal ingestion of toilet cleaner around 50 ml in the month of June. At that time, he had vomiting and respiratory distress, for which he required an emergency intubation, and through the course of illness, he then required tracheostomy at AIIMS. He was later evaluated with upper GI endoscopy, which showed grade 3B injury, that is the diffuse necrosis of the esophagus, and he was then managed with nasojejunal tube inserted, and following which he was on nasojejunal feed. So during the course of his illness, he then developed short segment esophageal stricture, for which he underwent multiple stricture dilatation in a private hospital. In October 2022, during the dilatation, he had an iatrogenic esophageal perforation, for which fully covered metallic stent was placed across the perforation, and subsequently he underwent surgical feeding jejunostomy for the feet. He then presented to us in GI surgery department in August 2021 with this background history and the procedure which was happened, and he had history of absolute dysphagia despite a stent being placed in the esophagus, and he was having significant poor weight gain in spite of feeding jejunostomy. He had a history of recurrent episodes of respiratory infection, for which he was evaluated with a bronchoscopy, and it showed a fistula between the esophagus and the trachea at the level of the left main bronchus. He had no psychiatric illness in the past. On examination, he was thin built with a BMI of 12.4, vitally stable, and other system examination was unremarkable. His routine investigations were normal. Upper GI endoscopy showed a stricture at the upper esophageal sphincter where they couldn't negotiate the scope. Laryngoscopy showed bilateral piriform sinus and post-cricoid area were scarred, and they were not able to negotiate the scope into the hypopharynx. And then we did a bronchoscopy, which showed a 2 cm tracheoesophageal fistula with stent eroding into the trachea. I'd like to call upon our radiology colleague to take you through the images of this patient.
So this is the frontal chest radiograph of this patient dated 28th July 2021. Bilateral lung fields and bilateral CP angles are clear. Cardiac silhouette appears normal, and there is a metallic stent in the mediastinum. However, the exact location of stent cannot be commented on this single AP radiograph. In this limited sections of CT chest dated 28th August 2021, this anterior air-filled column is the trachea, well seen on the axial, coronal, as well as the sagittal images. At the level of thoracic inlet, the esophageal stent is seen eroding into the left lateral wall of trachea and protruding into the tracheal lumen. The length of erosion is approximately 2 cm.
Thank you, Dr. Anjali. So this is a transnasal endoscopy. Here you can see the bilateral vocal cords, and when we go into the trachea, you can see the tip of the metallic stent that is protruding into the trachea. So when maneuvered into the right main bronchus, the right main bronchus was healthy. So you can see the secondary bronchiole, and the scope was maneuvered into the left main bronchus across the stent, where so this is the stent. You can see the granulation tissue in the left main bronchus. So basically the stent is eroded into the left main bronchus coming into the trachea. So based on the history and the images, we made a diagnosis of corrosive esophageal injury post stent placement with partial stent migration into the bronchus and trachea. So we discussed in the multidisciplinary team, and we decided to approach through the thoracotomy and stent removal. So the major challenge here is that the endoscopic removal was abstained due to the dense granulation in the left main bronchus and risk of worsening the tracheal fistula and leading to sudden collapse of the patient. And we also had a backup of cardiopulmonary bypass, as when if the fistula is big and if the patient desaturates, we had to put him in the cardiopulmonary bypass. Again, still we had a challenge in that. We still had a low threshold. The reason because during the cardiopulmonary bypass, the patient will be put into high anti-coagulation. So in case of corrosive, there will be dense adhesions around the lung and the esophagus, which will cause increased bleeding, and still it causes difficulty during our surgery. So here you can see the stent which is migrated from the esophagus into the left main bronchus into the trachea. So we took the patient in CTVS OT on 9th of September. In view of difficult airway, an awake fiber optic intubation was attempted, but the patient was not able to ventilate on inflating the cuff. Then the tube was withdrawn a bit and it was placed just above the tracheal stent. So when the patient was positioned into a left lateral position, the esophageal stent which is eroded into the trachea, it fell and caused obstruction of the endotracheal tube. So ultimately he was not able to maintain the saturation and hence we had to abandon the procedure. Later he then developed central line associated bloodstream infection and IJV thrombus, for which he was managed conservatively with anticoagulants, and subsequently because of the anticoagulant he started having multiple bouts of hemoptysis. So it was likely due to the stent induced tracheal injury, as the CT pulmonary angiogram was negative. So this was a time we decided that we had to take him to the OT with a bigger anesthesia team and all the backups, keeping in mind all the challenges we had faced during the first surgery. So again we took him to OT in CTVS on 29th of October, and this time we did a single lung ventilation. Usually for single lung ventilation, double lumen endotracheal tube is being used, but in this case we have a narrow space because of the stent eroding into the trachea where double lumen can't be used. So here a small size single lumen endotracheal tube was inserted into the right main bronchus, thereby the saturation was maintained. So here in this video, the patient was put in the left lateral position and the access was through the fifth intercostal space in the right posterolateral thoracotomy. So once we entered, the lung was adhered to the thorax, which was slowly, the adhesions were all taken down. So here we are mobilizing the lung. Once this adhesion is taken down, the lung is lifted, then we could reach near the esophagus. Here the asagos vein, which is looping the esophagus, is being divided, to which this helps the esophagus to be looped so that we can open the esophagus and remove the stent. So we looped it and we opened it, and this video shows the stent removal. Once we opened, we saw the stent and we carefully retrieved the stent in toto. Here you can see at the time of removal the gush of air. So this denotes the presence of tracheoesophageal fistula. So this is the entire stent removed in toto, and this is the site where we opened the esophagus. So now the fistula has been, the tracheal fistula has been repaired with suture, and the segment of the esophagus where it was eroded has been divided, and the proximal and the distal esophagus was ligated. This repaired fistula is still buttressed with intercostal muscle. This is the intercostal muscle with the pedicle has been harvested and it is placed over the fistula. So he was extubated on post-op day 1, and on post-op day 3 he had purulent discharge in the chest drains. So CT showed his right upper and lower lobe was collapsed and only the middle lobe was ventilated. He was requiring non-invasive ventilation. Subsequently, he was tapered to the room air, but still he had persistent right lung collapse with air leak. So the CT at that point of time which was done showed a small left broncho right pleural fistula with empyema. Since the fistula size was small, we decided to manage him conservatively. So with chest physiotherapy, the right lung expanded well and eventually the fistula closed by the time of around 2 months. He was then discharged after 4 months after the surgery with a plan of definitive surgery to give adequate time for the fistula to heal.
In this immediate post-op CT dated November 2021, there is surgical emphysema in the right anterior chest wall, right-sided pneumothorax and empyema with collapse of the right upper lobe. This is the right main bronchus and this is the left main bronchus. There is an air-filled fistulous tract seen extending from the left main bronchus towards the right pleural cavity, suggestive of left broncho, right pleural fistula. In the next follow-up CT done 6 months later, there is persistence of this fistulous tract. However, there is significant reduction in the volume of collection in the right pleural cavity. And this is the current scan done 2 months ago, where there is complete closure of the fistulous tract with no significant air or fluid collection in the right pleural cavity.
So after giving adequate time for the fistula to heal, he was then readmitted on 6th of January 2023 for definitive surgery. He gained weight on tube feeding. Unfortunately, he had a swelling in the left suprascapular area, which on imaging and FNAC showed a benign tumor of fibromatosis. And since we had to deal with the current illness, we consulted with the general surgery and we decided him to put him on tamoxifen and deal with this in the later date. On examination, though he gained weight, still his BMI was 14.5 and chest showed a mild decreased air entry on the right side. His routine investigations were normal and the bronchoscopy showed mild stenosis in the mid-trachea, and the transnasal endoscopy showed bilateral PFS and the epiglottis. Bilateral PFS was scarred and the epiglottis was fixed to the posterior pharyngeal wall. So we plan to replace the esophagus in the form of colon in terms of colonic pull-up, and since he had a stricture in the pharynx itself, so here we have to create a neopharynx with the help of the colon. Still, even in this surgery, we had to face few challenges, as the epiglottis was fixed and there were scars. So the intubation itself was a difficult, and secondly, even after intubation, there was high likelihood of the airway to get opened up at the site of fistula, which was healed when the patient was put on positive pressure ventilation. So this is the laryngoscopy video here, which shows the bilateral epiglottis with the arytenoids, and the post-cricoid area was scarred. And so once we enter into the trachea, so here you can see the healed fistula in the trachea. This is the site where the stent was protruding in, and this is the post-cricoid scar and the scarred bands in the right piriform sinus. So in the surgery, once he was intubated, the bands are released and the epiglottis has been freed. And then we proceeded with retrosternal colonic pull-up and creation of a neopharynx with the help of the colon. So for which he was approached through the right incision, so where the muscle flap has been raised. Here the thyroid cartilage and the thyroid gland has been dissected off to retract the thyroid cartilage. This is the thyroid gland which has been retracted. Here the inferior constrictor muscle between the thyroid gland and the thyroid cartilage is being dissected to free the superior corner of the thyroid cartilage. So now in this, here the right piriform sinus mucosa which is stuck to the thyroid cartilage is dissected off. So here there is the thyroid cartilage and the right piriform sinus mucosa which is freed from the thyroid cartilage. So this is basically we are opening up the piriform sinus which is scarred, so that to open up the pharynx where we can do the anastomosis. So this is the piriform sinus opening, right piriform sinus. So here we have opened the pharynx and stay sutures are being taken to prepare the area for colonic anastomosis. So here you can see the thyroid cartilage which is lifted up. This is the larynx through which the endotracheal tube is going inside. This is the entire right piriform sinus mucosa which was stuck to the thyroid cartilage which has been taken down. This is the left piriform sinus, and through which you can see the hypopharynx. So once the neck part is done, we decided to take the colon. We decided the right colon, which is we divided the colon just proximal to the cecum, and distally we divided distal to the splenic flexure. So this colon has got few major arteries. So this entire conduit is based on the ascending branch of the left colonic artery. So in that we had to ligate the middle colic artery and colonic branch of the ileocolic. So before ligating the clamps are being placed in those two arteries, and the pulsation in the arcade, which is seen around the colon, has been tested. So you can see the pulsation of the vessel. So the vessels are pulsating well even after clamping the artery. So once this has been confirmed, the arteries are clamped and it is divided and the conduit is taken up. So the length has been assessed so as to conduit has to reach the neck. Once the length is assessed, distillate is divided and the colon is taken through the retrosternal route. So here the colon is split open and the anastomosis is started. So now you can hear the voice of Professor Alok sir, who is beautifully explaining the anastomosis.
देखो दादा बेटा ये ट्यूब जा रही है अंदर पहुँच कर दो थोड़ा इनको ये पीछे एरिथनॉइड्स दिख रहे हैं देख रहे हैं आप ये दोनों एरिथनॉइड दिख रहे हैं तो ट्यूब जा रही है ये हाइपोफैरिंक्स बन रहा है तो ये हाँ हमने वर्टिकली ओपन किया है और यहाँ पे जो सर्कुलर ओपनिंग बनी है वर्टिकल बने उसको यूँ सर्कल पे लगा देंगे पीछे पैच करके
So here the colon has been anastomosed to the thyroid cartilage. So basically the wall of the colon is sutured to the thyroid cartilage so that the mucus of the colon will form a neomucosalization.
Taking it so that the lateral ala of the thyroid cartilage so that the mucosa comes like this under the ala of the thyroid cartilage. Basically make a mucosalized lateral piriform sinus.
So once this is done, the Ryle's tube is inserted into the colon, which is forming the neopharynx, and you can see the Ryle's tube going into the colon, and this anastomosis is then completed.
This is pharynx, this is larynx, IJV, colon, and colon attached here, carotid, done.
So this is the completed anastomosis, that is neopharynx created using the colon, and then we had multiple anastomosis to be done in the abdomen. So this is the cologastric anastomosis, and then he had a gastric outlet stricture also. So we had to do a Roux-en-Y gastrojejunostomy, jejunojejunostomy, and finally colocolic. So to summarize, in this you can see the colon has been taken as a conduit, and it is anastomosed to the pharynx to form a neopharynx, and down it is anastomosed to the stomach, and since he had obstruction here, we had to do a Roux-en-Y gastrojejunostomy. So the alimentary limb is completed through cologastric gastrojejunostomy, and it goes down here, and the biliopancreatic, that is the bile and the pancreatic fluid, will go through this limb, and here again the jejunum is anastomosed to complete the circuit. So this colon is then anastomosed and a feeding tube is placed into the jejunum for the feeding access. So he was extubated on post-op day 2. So initially the neck was kept open because of the edema in the colon, and by post-op day 10 all drains were removed, feed was started through the feeding tube, and the neck was also closed on post-op day 10. This is after the neck closure and after complete heal of the neck. He was discharged on post-op day 14 on FJ diet, and his weight increased to 36 kg, and he was planned for a swallow therapy on OPD basis. So in such patients where there is no sphincter now and we have created a neopharynx, the patient has to learn how to swallow. So for which on the follow-up, he underwent a functional endoscopic evaluation of swallowing, where the anastomosis was patent, he was able to swallow secretions, and still he is on swallow feed. He is continuing to have feed through the feeding tube, and which will be phased out over 3 to 6 months once he completely learn how to swallow. So this is the healed scar of the thorax during the first surgery and the abdominal surgery, and this is the happy patient after completing the definitive surgery. So he is still under the follow-up for the benign tumor, which will be planned for the resection in later date once he recovers from the current illness. Now I call upon Dr. Aman to take you through the review of literature.
So, review of literature. Prevalence of caustic injuries in India is to the tune of 2.5%. It occurs in different grades, with higher grades invariably ending in stricture formation. Endoscopic dilatation is the preferred first mainstay of treatment. Chad and Taravej et al. Described the outcome of dilatation and predictors of failed dilatation in their study of 55 patients with acid-induced corrosive esophageal strictures, in which a total of 308 dilatations were done. In them, favorable outcome in the form of complete cure was found in 25% of the patients, with rest of them having one or the other unfavorable outcome, of which perforation, that is the worst outcome, was present in 8 patients, that is around 12%. Inset shows a image of endoscopic dilatation with a through the scope balloon. The balloon is passed across the stricture and it exerts radial force uniformly on inflation, and here is shown a partially dilated stricture. Difficulties with dilatation. Identified factors associated with unfavorable outcomes of dilatation in patients with acid-induced corrosive esophageal strictures include a stricture length of more than 10 centimeter. Because such a stricture on balloon dilatation, the balloon will not exert a uniform radial force. Number of dilatation sessions required more than 6 per year, that is in a frequency of less than 2 months. A stricture that is unable to be dilated to more than 11 mm despite 3 sessions. For a normal swallow with a average sized bolus, at least a diameter of 14 mm in esophagus is required, and a concomitant cricopharyngeal stricture, because such strictures are difficult to dilate both for the endoscopist as well as for the patient to tolerate. With increasing risk factors, chances of injury may further increase, as in our patient. Stent perforation and migration. Of the mentioned complications, perforation is the most severe of them. The perforation can be self-limiting and can be managed conservatively or may require surgery in form of exclusion or diversion of esophagus. Use of stents is being considered increasingly in management of dilatation-induced perforation strictures. However, it is limited due to high incidence of stent migration to the tune of 25%, potential for hyperplastic response, and their high cost. Inset shows a small perforation proximal to a stricture with the concomitant contrast swallow showing active extravasation of the leak of contrast into the mediastinum. The lower image shows a SEMS which has bypassed the perforation site, and the contrast swallow does not show any extravasation along with a feed axis via an NG tube. In our case, patient was on dilatation schedule, following which he had iatrogenic perforation, for which he underwent SEMS placement. Probably secondary to distal stricture and acute inflammation, the stent migrated into the left mainstem bronchus through the trachea. Stent perforating outside esophagus and then entering into the trachea and occluding one of the bronchus poses a serious challenge. Post-SEMS removal, tracheoesophageal fistula repair posed previously mentioned challenges, with paucity of data on such repair and their further management. In the literature, only isolated case reports on TEF repair are present. The anecdotal ones are mostly single patient reports, where either if the patient is stable, fistula takedown and a pleural flap repair or an intercostal muscle flap is used to reinforce it, or in the sick patients, just a diversion esophagostomy and gastrostomy is done. The largest series is from PGI Chandigarh by Gupta and Kurdia et al., where 3 patients were presented, in whom 2 of them underwent repair of TEF with reinforcement via pleural flap, and the third one underwent an intercostal muscle flap buttressing. 2 of them required esophagectomy and retrosternal colonic pull-up for the management of stricture, and in one, a short segment resection and anastomosis was done. All 3 patients improved and were discharged. This is a described technique by Han et al. Of double patch technique for repair of tracheoesophageal fistulas. A paramedian opening in the esophagus is made opposite the fistula site, generating a short patch and a long patch. The short patch is used as the inner layer for closure and buttressing for closure of the TEF, and the long patch is used as a second layer buttressing the first patch. They have referred to it as the double patch technique. However, in their series, there were 5 patients of which only 1 had corrosive. Rest of the 4 had traumatic esophageal perforation, so they could find a healthy esophagus. Management of associated high pharyngeal strictures. Reconstruction for high pharyngeal strictures entails construction of a neopharynx. Usual methods described are flaps that are molded to form neopharynx. They can be sternocleidomastoid myocutaneous flap, forearm myocutaneous flap, pectoralis major myocutaneous flap. In our case, neopharynx was reconstructed using the colon conduit itself. This is an innovative method adapted by our ENT colleagues. Summary. Mainstay of management of corrosive esophageal strictures remains dilatation in those with a favorable anatomy. Predictors of failed or difficult dilatation are known, as already mentioned. Increasing number of contained esophageal perforations are being managed with stents. Stent-induced tracheoesophageal fistula poses unique challenges, and literature pertaining to their management is very limited. Multidisciplinary team effort is essential to improve outcomes in such complicated cases. These were our team members from Department of ENT, Thoracic Surgery, Radiology, Cardiac Anesthesia and General Anesthesia, with the fulcrum as Department of GI Surgery. Thank you.
Thank you, sir. Thank you very much. We took 2 calculated risks based on our 250 cases of colonic pull-up in our department. The first risk was whether to take out the stent. Whenever we need to take out the stent, then the air will leak outside, because the stent was going from the esophagus outside, then entering into the trachea. So if you take it out, then within 5 minutes you have to enter and close that, otherwise there will be brain death. So that was the first one. The second one was when to do the last surgery. Before you at that time, if you do intubation and inflate, that the patches could have opened up, and then we are back to square one. Now this case was operated under it's a big team of anesthesia from CTVS. Dr. Chauhan managed it throughout 4.5 hours of surgery. The patient had a BP of 70/40. That shows that possibly the patient got brain damage by the time we finished the surgery. We couldn't have reverted back any time, but I don't know how he managed it. The patient came out absolutely free and uneventful recovery. So that was the great thing by him. We took up this case based on one of the case done in surgery, which we are also part of it. There was a patient on whose neck a tractor had trod over, and he had a huge tracheoesophageal fistula. The same thing was there, so we planned that we would do it in CTVS OT, doing a heart-lung machine complete diversion and then repair. It was done very smoothly. But the problem here was, if you do heart-lung machine, then you have to keep him on heparin, and the dense adhesions you saw, while doing them, the patient got bled to death. So that is how he did some alternate management. So I give full credit to Dr. Chauhan. Corrosive stricture is a very, very rampant thing. We are not able to see in literature, no real epidemiological data, but Professor Govind and the gastroenterology people are already, I'm a part of it, making a corrosive guideline. We just finished a few days back. So I would request him to say a few words. I think we have to create an awareness in the society, and a lot of steps have to be taken, because it really doesn't kill, it tortures for years together to come back to lifetime. Thank you. Dr. Govind, you need to say something.
I think corrosive is a very disabling method of suicide or homicide. They don't kill life, they don't take life, but it leads to catastrophe to esophagus and stomach and many other organs. So recently we made a guidelines, it's called Indian Guidelines on Caustic Injury. This is done on behalf of Indian Society of Gastroenterology. So, and we have put all the guidelines, what are the patients who should undergo dilatation, when to do surgery, and all those things. I just want a forum to discuss about that.
Any questions? So he had ongoing chronic inflammation because of the recurrent respiratory tract infection, but still had to take a decision.
Most of these patients are skin and bones, and they, in spite of our waiting list of corrosives is about 2 years, but they hardly cross 30. But we have been doing 250 plus. They can wait very soon. Very soon means about 6 months to 1. Almost
I
within
think
that time.
the point is said that the skin bone is one thing. If somebody is corrosive, he or she will not eat for many months, maybe a year, but keep dilating esophagus, keep human, but just extremely complete nutrition. Over the 6 months to 1 year, they all reduce weight. The skin, they are only skin and bone. So therefore, the best thing to mind, I'm very convinced about it. You must do FJ as soon as you go to grade 2B and 3A is fine. And then keep doing data, whatever you want to do like this. And it's a pH or clean, preserve body mass. And we underdo FJ.
Yes.
Taking psychiatric
Yes.
can happen all throughout psychiatric evaluation.
So before they get discharged and before the surgery, there are 2 times we take psychiatric. Thank you.